And I hope we are going to help solve this problem as much as we can. So what are the objectives we have to achieve today? We are trying to understand the anatomy and development of the brain, ventricles, and germinal matrix, because if we know the anatomy and the embryology, we'll be aware of the changes that occur in utero and affect. And if the baby is born premature, we will know the defect. Where is the defect, and why is this baby at high risk for GM-IVH? Number two, to know the pathophysiology, pathogenesis, risk factors, etiology, and clinical presentations and complications. To understand any disease, we should know how it happens, which means the pathophysiology, and then how it occurs, pathogenesis, and then the pathological change. To know the risk factors also, and etiology will help us in the prevention, which means we do try to avoid all the risk factors or deal with them as early as possible. And comes the clinical presentation and complication in order to try to do early detection and early management and prevent complications, and if they occur, we have to deal with them. And of course, we need to know the grading of the GM-IVH, which is the basic for management and for the prognosis. And to be familiar with the diagnosis and management of GM-IVH and its complications, to identify antenatal and perinatal factors associated with decreased risk factors. And this is the basis. This represents the basic element for prevention of GM-IVH. And the core concept of this presentation is prevention of GM-IVH. And this is going to be the ongoing message. If we know exactly how we can do our best to prevent GM-IVH, which is not an easy task, it's very, very tough job, but we'll try to do it. So this is a preview of the different subtitles I'm going to deal with: definition, anatomy, and embryology, and we'll discuss some issues about the germinal matrix, especially in the preterm babies, and then cerebral blood flow and autoregulation, which is one of the major issues in the pathogenesis and pathology of GM-IVH. And of course, we go to pathophysiology, pathogenesis, pathology, and pathological change with the gross anatomy and microscopic changes of post-mortem brain samples of babies who died with GM-IVH. And then we'll go to epidemiology to know how bad is the problem, whether nationwide or worldwide. And this will include morbidity and mortality. And then comes the clinical presentation, which will take us to the differential diagnosis, how we can diagnose GM-IVH, and the basic tool of diagnosis will be imaging, especially the head ultrasound. And then we'll discuss how we should screen for GM-IVH in preterm babies and why we should screen for this problem. Discuss some complications, whether acute or chronic, and then how the complications occur, pathogenesis of complications, management of GM and IVH and its complications, prognosis, and here comes the prevention, which is the most important part in this presentation. Prevention of GM-IVH and its complications, and the ongoing message and references. Okay, GM-IVH is a significant cause of both morbidity and mortality and actually it is a disease of prematurity. It does not affect term babies, and intraventricular hemorrhage in the term baby is a totally different story pathologically and pathogenesis point of view. So, and this is not only in your unit, it's worldwide. The sequelae of GM-IVH, which are either short-term or long-term, can result in lifelong neurologic deficits, which is very bad. We try to avoid, because those babies could have some developmental delay and seizures that stays for good. So, and diagnose, the gold standard of diagnosis is the cranial ultrasound, as we are going to see. And we are going to see the importance of the screening and serial examination. And this question is what we face every day, especially when we are talking to the parents, updating them about their baby. If you have a baby with GM-IVH, the question is this child going to survive? And if yes, will he or she has long-term sequelae? And what are these sequelae, and what is the percentage and possibility of having these major issues? And the answer for these questions will guide our medical decisions. So, as we are going to see, the classification and grading depends on the anatomic involvement as seen by by cranial ultrasound, and the most serious part if there is intraparenchymal hemorrhage or not. If the hemorrhage extended to the brain parenchyma or not, because this is going to take us from the mild, moderate IVH, GM-IVH to the severe form with bad prognosis. Okay? And it is still a serious problem, especially in babies less than 1 kilogram. So what is germinal matrix bleed, GM-IVH? It is bleeding in the brain that starts primarily in the germinal matrix and then may or may not go to ventricles, may or may not go to the brain parenchyma. So just a few and brief idea about the anatomy of the ventricular system, because this will help us understand what happens in GM-IVH and how complications issues happen, how complications happen. The ventricles are a communicating network of cavities through which or into which the CSF circulates. We have two lateral ventricles, one on each cerebral hemisphere. We have the third ventricle, and then where both ventricles, lateral ventricles, will drain CSF, and comes the cerebral aqueduct, which is the site of obstruction when there is complications, and then comes the fourth ventricle. The choroid plexus are located within the lateral third and fourth ventricles, and they are the structures that produce the CSF. And this is done through ependymal cells. What are the ependymal cells? The ependyma is the lining of the ventricles, the thin layer that lines the ventricles. And this picture shows you the parasagittal and coronal sections of the brain, and it shows you the lateral ventricles, and then the third ventricle, and then comes the fourth ventricle, and the connections between them, and the structure of each. Like the lateral ventricles have frontal horn, occipital horn, body, and I will send you this presentation to know in details the structures. So the choroid plexus of the four ventricles will form the CSF, and the CSF will flow from the ventricles, lateral ventricle, foramen of aqueduct of Sylvius, and then foramen of Magendie, and then foramen of Luschka go to the subarachnoid space. And this CSF is in a continuous circulation. And if there is interruption of this circulation, complications occur, mainly hydrocephalus. CSF drains after that into the dural venous sinuses through the arachnoid villi, which are and granulations and capillary absorption. Okay. So there is a continuous circulation of the CSF, production, flow through the ventricles and foramina, and go to the subarachnoid space. And if it is interrupted, there will be hydrocephalus. And this is a coronal section of the brain, and it shows you the ependyma. The ependyma is the lining of the ventricle. And then under the ependyma lies the germinal matrix, as we are going to discuss. And the basic line in understanding GM-IVH is to know exactly anatomy, embryology, and developmental change, and what are the structures in the germinal matrix. And because this is the source of the GM-IVH. And as we notice, the ventricular system lies in the middle of the brain, surrounding with extremely important structures. In addition to the parenchyma of the brain, you have the caudate nucleus, you have the internal capsule, you have the pyramidal tracts, and this explains the complications of GMS-IVH when it's severe and when it affects the surrounding structures in a very immature brain in a very critical stage of development. So it is something very serious. There is hemorrhage in a very, very, very important structure within the brain that can affect the ventricles and the surrounding structures of the brain and the parenchyma. Okay. These are the structures. As we mentioned, the most important is the pyramidal tracts and then the parenchyma and the white matter in the parenchyma. Because GM-IVH could be complicated with white matter injury. And this illustration of the blood supply, and most of the blood supply to the ventricles comes from the anterior and mid-cerebral arteries. And the arteries will give you capillaries. And the capillaries in the germinal matrix are very, very specific. They are even different from the structure of normal capillaries. And then the capillaries will drain into venules and then veins. And also this is illustration of the important structures surrounding the ventricular system. Okay, development of the brain, ventricles, and germinal matrix. It starts as early as 4 weeks of gestational age. And the ventricles develop from the central lumen of the embryonic neural tube. And it is in the form of 3 cerebral vesicles, 3 vesicles that will form the forebrain, the midbrain, and the hindbrain. And the forebrain is where we can find the ventricular system with the germinal matrix evolving inside those ventricles lined with ependyma. And as you see, this is the illustration of germinal matrix and its relation to the surrounding structures. And in the preterm babies, it has two major functions: neurogenesis and vasogenesis, or formation of blood vessels. So, what is the germinal matrix and the ependyme? Germinal matrix is an intersection of neurogenesis and angiogenesis. Angiogenesis, not vasogenesis. I'm sorry, angiogenesis. It starts around the age of 20 weeks to form. No, before that, before this, the germinal matrix starts to form neuronal cells and blood vessels. And this is in the germinal matrix under the ependyma, which is the lining of the ventricle. And the size of the vessels increases and reaches its maximum size by the age of 23 to 26 weeks. That's why if you have a baby who is born before 26 weeks, the germinal matrix vasculature is still very immature. And the neurogenesis is of extreme importance because the germinal matrix forms neurons that migrate to the lung, to the brain parenchyma, and form the neuronal structures of the brain. And luckily enough, this process ends by 20 weeks of gestation. But after that comes another process called glial cell precursors, where the germinal matrix keeps doing the production of glial cell precursors, which will also migrate and form the glial cells in the rest of the brain. But unfortunately, we don't know exactly what happens when these glial cells precursors get damaged. At the age of 28 weeks, the germinal matrix vasculature that was very maximum at this 23, 26 weeks will start to involute. And by 36 weeks gestation, it should be very residual, in the form of residual. That's why we don't find this kind or type of hemorrhage in term babies. We see it only in preterm babies. And you have to be very careful. Never, never, ever say GM-IVH in a term baby. The term baby could have intraventricular hemorrhage, but the pathogenesis is totally different. Okay? Of course, this process of neurogenesis and angiogenesis is associated with a lot of cellular underlying mechanisms, mediators, interleukins, whatever, but we are not going to discuss these details because it's a big issue. So if this is a cross section, where is this is the skull, bone, cortical plate, and then here is the ependyma. This is the ependyma, and here is the subependymal space where we can find the germinal matrix. And the germinal matrix, if we do cross section in the vessels, they look like capillaries, but they are not mature capillaries. They have some deficiencies of the fibronectin. There is a deficit of the fibronectin, deficiency of the pericytes, and tight junctions also are lacking. So it is very fragile structure. So the germinal matrix before 36 weeks have a lot of blood vessels that are very fragile. Okay? In an area that is important, very important in the function of the brain, because these are the germinal matrix precursors that form neuronal cells, but luckily enough, the neurogenesis stops by 20 weeks of gestation, but the glial cell precursor continues. So if there is damage, it will affect the glial cell precursors. And this illustrates the migration of the neurons and glial cell precursors from the germinal matrix to the rest of the brain. So germinal matrix is extremely important. And this is the same story. And this is the blood supply of the germinal matrix, where you have the hibunar artery that gives you arterioles, and then the capillaries of the germinal matrix, which are very specific in structure and they're immature and fragile. And then comes the venules and the veins, which will end up draining in the cerebral veins. This is a more sophisticated structure with it is cellular structure. We don't need to go into these details, but it shows you the interaction between the germinal matrix structure, function, immune function, inflammatory and pro-inflammatory issues, because GM-IVH is not only just bleeding, it is also it's a multifactorial issue, and is associated with pro and inflammatory issues, immune problems. It's a big deal, but we cannot go in deep into these details. So the germinal matrix is very fragile, as we mentioned, because it's highly cellular, richly vascularized, subependymal structure, and also the metabolic needs of this area is very high, and this area is very rich in mitochondria, and that's why it's very sensitive to injury, hypoxia, or decreased perfusion. Okay, and then, as we said, at the age of 28 weeks, it starts to involute, and by 36 weeks, the involution process is complete. So babies born at 28 weeks are different from babies born before 36 weeks, different from babies born at 23 to 26 weeks. So in preterm babies, the germinal matrix is very vulnerable to hemorrhage and injury. And this is in response to hemodynamic instability. As we are going to see, the main factors in the pathogenesis of GM-IVH is germinal matrix fragility and immaturity. And number two is hemodynamic instability affecting cerebral blood flow because of lack of autoregulatory mechanisms, as we are going to see. Okay? And yes, they are delicate and fragile, and there is no tight junctions, there is no fibronectin enough, there is no pericytes enough to support this vasculature. Okay? Another important issue is about the venous drainage. The venous drainage that comes from these germinal matrix vessels have a very unique flow. It goes into a U-turned fashion to go to the internal cerebral vein. Going into this U-turn makes congestion and venous congestion possibility high. And when the venous congestion occurs, the venous pressure increases, and the germinal matrix also having increased pressure and more prone to hemorrhage. Okay? And this was studied by the venography. Okay, so we are done with the germinal matrix fragility and immaturity, and we know why, based on physiologic and anatomic and developmental issues. Here comes the second main issue in the pathogenesis of GM-IVH, which is immaturity of the autoregulation of the cerebral blood flow. Normally in adults or in term babies, and to a less extent in preterm babies, and the more the baby is immature, the more the autoregulation immaturity is. When there is fluctuation in the blood pressure, the cerebral flow is maintained by autoregulatory mechanisms. If the pressure increases, there is vasoconstriction. If the pressure drops, there is vasodilatation. This mechanism is called autoregulation of cerebral blood flow. Okay? And it determines also the cerebral blood flow pressure. Cerebral perfusion pressure, CPP, which is extremely important. So cerebral blood flow depends on the cerebral perfusion pressure, which is regulated by vasoconstriction, vasodilatation in response to changes in cerebral blood flow. And this mechanism is extremely immature, depending on the degree of immaturity, but it is preserved in term babies and older children. And we are not going to go into these details, but it's important for anyone who is more interested. So autoregulation in preterm babies is incomplete, and there is, because of the underdeveloped cerebral vasculature, that cannot yet autoregulate completely. There might be some degree of autoregulation in some preterm babies, but this autoregulation could be hindered or affected by other factors like hypoxia, acidosis, anemia, as we are going to see. Okay? And they did check the cerebral blood flow in even term babies, and they found that it is very close to the ischemic level. And compared to the adult cerebral blood flow, the brain of the baby is 17% of the body mass and receives 17% of the cardiac output, compared to adult, where the brain mass is 2% and the blood supply is 25% of the cardiac output. So from the get-go, the cerebral blood flow of the term baby compared to adults is already on the borderline. In the preterm baby, it is very deficient because the autoregulatory mechanisms that try to maintain it stable are deficient and immature. So we have two combinations. We have the germinal matrix fragility, and we have the problems with the cerebral blood flow secondary to deficient and immature autoregulatory mechanisms, depending on vasoconstriction and vasodilatation in response to changes in blood pressure and in order to maintain cerebral perfusion pressure. And usually, irrespective of the gestational age, usually cerebral blood flow increases during the first day of life up to the first week of life. Okay, so in preterm babies, hypotension can cause cerebral blood flow to drop. And also it is important that the cerebral blood flow in preterm babies depends on the cardiac cycle. Meaning, if you have a baby with hypotension, the cerebral blood flow during diastole is almost zero. During systole, this is where the cerebral blood flow occurs. So systolic blood pressure is extremely important in maintaining cerebral blood flow in the preterm babies. Okay? So other factors that may affect cerebral blood flow and cause fluctuations. The problem in GM-IVH, it is not only in the decreased or high cerebral blood flow, but it is in the fluctuations. The flow might be low and in a second will be high, and the other way around. These fluctuations in the presence of fragile vessels in the germinal matrix will cause the bleed. Other factors that make the autoregulatory mechanisms weak and will add also to the problem of IVH, GM-IVH, anemia, hypercarbia, acidemia, hypoglycemia, asphyxia, and then be careful about abrupt elevation of systemic blood pressure. If you have a baby, a preterm baby who has hypotension, you have to go up slowly on the blood pressure. If you go up suddenly increasing the blood pressure, this fluctuation will cause hemorrhage. Also, rapid volume expansions. That's why we don't like to give boluses to preterm babies unless we have to do, and we give it slower than in term babies. Okay? However, this is some of the bad news. The current clinical practices do not prevent neurologic injuries in critically ill neonates, and generalized blood pressure guidelines are still inadequate. So sometimes GM-IVH is inevitable, and whatever we can do, it will happen. But we try to make it prevent it as much as we can and make it less severe as much as we can, and then less complications as much as we can. Okay? Okay, what happens in GMS? In GM-IVH? Site of bleeding, it is the subependymal germinal matrix in the lateral ventricles. And as we said, this site of neural proliferation, neuroblasts, or glioblast precursors, and was angiogenesis. So this is a very important critical site. So this is the site of the bleed. Okay? And this, because the site of the bleed is very fragile, very important, metabolically very active, and have important functions for the brain, neuronal formation, neuronal migration, and glial cell precursor migration. So damage to this area is extremely important. So even grade 1 of GM-IVH localized in the germinal matrix has its sequelae, and it is not a benign condition. And this is, as I told you, the pathology or pathogenesis shows it is multifactorial, and there is a correlation between the immune system, complement system, the erythrocyte lysis that happens, and will release iron, and iron will turn into hemosiderin, and all these are irritant and toxic materials to the brain. And also we have, in addition to the two underlying mechanisms, we have other factors that make the problem more serious, which, as we are going to talk about, the risk factors, the mechanical ventilation, the anemia, whatever. Okay? And there is also cytokines involved, and if anyone interested in like these issues, he can go deeper into this aspect. So we have germinal matrix that is immature, we have autoregulatory mechanisms that are immature, affecting the cerebral blood flow. We have underlying problems of prematurity, starting from anemia, mechanical ventilation, hypoxia, acid-base balance problem. So the bleeding starts in the GM, and then may or may not go to the ventricles, and then may or may not go to the lung, to the brain parenchyma. Okay. And the most important factor, based on the fact that germinal matrix is fragile and cerebral blood flow is lacking autoregulation, systemic blood pressure problems comes number one in the risk factors. And if we have fluctuations in blood pressure or in blood volume, as we said, this is going to add to the problem. And usually it's multiple issues and it's multifactorial problem. And then what are the other more events that add to the problem? Like mechanical ventilation, when there is asynchrony between the baby's breathing, spontaneous breathing, and the breath is given by the vent, or doing noxious procedures like tracheal suctioning, frequent tracheal suctioning, pneumothorax, rapid volume changes, giving sodium bicarb, and intubation. Intubation is not a benign procedure. It's a very aggressive, and it causes vagal stimulation and causes irritation and affects reflexly the blood pressure, cerebral blood flow, and can multiple attempts of intubation, especially in the first few minutes of life, can precipitate a GM-IVH. Okay. So if we need to go into steps of the bleed, there is step number one, loss of cerebral autoregulation, and which is followed by rapid changes in cerebral blood flow, and then GM bleed. The pathogenesis of grade 4, as we are going to see, which is post-ventricular hemorrhagic infarction, is different. That's why some people don't call it grade 4. Some people call it post-ventricular hemorrhagic infarcts, because the pathology and the pathogenesis is different. What happens in PVHI, the hemorrhage comes from the veins because of hemorrhagic infarctions. That venous infarction, because of the terminal veins, as we said, that go into the U shape, and its feeder vessels probably primarily related to increased venous pressure following or associated with development of low-grade hemorrhage. So the story starts with a grade 1 or grade 2 or even grade 3 hemorrhage, but because of increased venous pressure, increased venous congestion, there will be venous infarction, which is PVHI, which was called grade 4 by some of the people. Okay. So regardless of the gestational age at birth, most GM-IVH develop within the first few days of birth, actually during the first day of life. This is related to accelerated maturation of the germinal matrix. It is not uncommon to detect hemorrhage soon after admission in 16%, hemorrhage diagnosed within first hour, and up to 50% within 6 hours or the first day. And same story. Okay, pathology. This study was done 1988, and this is the only study I found about the pathological change that we can see in the GM-IVH. And they divide it into 7 stages. Pathologically, 7 stages. The gross appearance, as you see, the lateral ventricles, and then the third ventricle is full of blood. And you see the amount of blood that can be accommodated in the ventricular system is huge. That's why in the clinical presentation, we can find the baby, some babies might become shocky and have catastrophic presentation. Okay, and after that, there is extension to the parenchyma. And in the parenchyma, there is a hematoma. And this hematoma will have some color changes depending on the hemolysis of red cells. And after some time, there will be a cyst formation. And these are the 7 stages. And also, as you see, ventricular dilatation. What might end up in ventricular dilatation, post-hemorrhagic ventricular dilatation, or even hydrocephalus. Okay, these are the pathological changes by the naked eye, the gross change. They did microscopic examination, low power and high power, and also they divided it into 7 stages, where you can find excess of red cells in the first and second stages, and then hemolysis of the cells starts. You don't find red cells, but you start find iron, and the iron will turn into hemosiderin, and then you will have a space, a cavity, and this is the wall of the cyst, and it will end up having extension into the, as we said, into the parenchyma and formation of cysts. And they use different stains, and then use the high power examination, which gave them the same 7 stages. And the beauty of this study is that they did a correlation between pathological changes and ultrasound findings. And the other issue is that this study made a temporal correlation between the changes and the time of occurrence. And this is extremely important because sometimes we have GM-IVH and we don't know, did it start in utero, start in the first hour, first day, first 3 weeks or 7 days, and this could be of medical legal importance. So based on the if the baby dies and we do the post-mortem, based on that we can know what stage is the baby having now, and we can decide when did the GM-IVH started. Okay. Yes, this is another sample. Also, this is the cellular, if you go to the cellular mechanisms, and this is a more sophisticated study that is working on the cellular change. This is the normal germinal matrix, and this is the germinal matrix when the red cell starts to leak into the ventricular cavity, and you find a lot of intervention between inflammatory biomarkers and precursors and immunological issues. And so you find monocytes, lymphocytes, red cells, a lot of sophisticated issues, but GM-IVH is not a simple hemorrhage. It's a multifactorial hemorrhage caused by multifactorial issues, and there is multifactorial factors intervening, including the inflammatory system, even the immune system. Okay? Grading. Here comes the most important part of the diagnosis, which is the grading. And based on the grading, the treatment and management will be decided, and also the prognosis. We have two grading systems, the papille and the Volpi. And the difference is a little bit, not big deal. And I prefer the old one, the papille one, which is much easier. We have grade 1, grade 2, grade 3, and grade 4, or periventricular hemorrhagic infarction. You can call it either way. So we have two grading systems, the papille and the Volpi. This is older than that. In the papille, we have grade 1, just bleeding inside the germinal matrix. Grade 2, the bleed extends to the ventricle but without dilatation. Grade 3, with dilatation of the ventricle. Grade 4, it extends outside to the parenchyma. The Volpi used more sophisticated grading with, I don't know how, it's not easy to do it, but this is what he proposed. Grade 1 germinal matrix hemorrhage with or without IVH less than 10% of the ventricle filled with blood. So he included grade 1 and some of the grade 2 who have less than 10% bleed in the ventricle. Then grade 2, 10 to 15% of the ventricle filled with blood. Grade 3, more than 50%, of course, with ventricular dilatation, and then the periventricular hemorrhagic infarction. You can go either way, but this is easier. And you can go to grade 4, you call it periventricular hemorrhagic infarction. It's not a big deal. Okay? And then the basics, and this is another example. This is a coronal section, which shows you the grade 1, blood in the germinal matrix. Grade 2, extending to the ventricle. Grade 3, ventricular dilatation. Grade 4, or periventricular hemorrhagic infarction with parenchymal involvement. The basics on which the grading was done is the cranial ultrasound. Same story. Same story. Okay. So I know that you do ultrasound by yourself. I'm not a sonographer. I never did any ultrasound for cranial or abdominal or cardiac, but I know you are expert in this area. So this is a coronal section with tiny hemorrhage starting on one side, because it could be one side, both sides. So this is grade 1. And then this is still grade 1, but this is a parasagittal section. And then grade 2 started to go into the ventricle, as you see. And then comes grade 3. There is dilatation of the ventricular system. As you see how dilated the ventricular system is. And then comes the grade 4, or periventricular hemorrhagic infarction. Yes, as you see. Okay? And then this is one of the complications when you can find a porencephalic cyst. When you have post-hemorrhagic ventricular infarct, it might end up in having a cyst connected to the cavity of the ventricle called porencephalic cyst. What are the risk factors? Number 1 and number 2 and number 10 is prematurity. Prematurity. It is a disease of prematurity. And then we have some other risk factors. I will talk about them in separate, and then we can classify them into maternal, antenatal, perinatal, postnatal. It's up to you. So prematurity and prematurity. Some other risk factor, rapid volume expansion, and we explained why. Asynchrony between mechanically ventilated baby breaths and spontaneous breaths, because this will increase the venous pressure and will cause more congestion and will more elevation of the pressure in the germinal matrix vasculature. Hypertension or hypotension, and with hypotension there is beat-to-beat variability. As we said, coagulopathy, which is a risk factor for any bleeding, not specific for GM-IVH. Respiratory disturbances, hypo or hypercarbia, hypoxemia. You know that the high or low CO2 can cause hemorrhage, but only low oxygen can cause hemorrhage. Be careful about that. Pneumothorax, rapid alteration in blood gases. Yes, if you have a baby on the vent and the blood gas is horrible, don't be aggressive in correction. Just go slow. Go up or down on your parameters slow. Don't go from hypercarbia to hypocarbia. Okay? From hypoventilated to hyperventilated baby. It's not a good idea. You are precipitating IVH. Acidosis, because acidosis can affect the autoregulatory mechanisms and interfere with the action. Hypertonic solutions, and the most common one is the sodium bicarb. Don't give any boluses of sodium bicarb. You can give a drip, as I told you before, if you need to treat metabolic acidosis in a preterm baby who is stable, day 2 or 3, you can give sodium bicarb drip over 24 hours, and even less if the gas corrects rapidly, and don't give any boluses. Anemia, because it will add to the hypoxia and will add to the decreased cerebral blood flow and perfusion. Of course, vacuum-assisted delivery, this is antenatal. Frequent handling. Yes, if you have a preterm baby, don't let the nurse go every second and do something to the baby and move the baby up and down, right and left. The movement of the baby is too much, is not good for the GM-IVH. And also head position, as we are going to see. The head position of the preterm baby should be in the midline, not to one side, and should be, the head of the incubator should be elevated a little bit. Tracheal suctioning and intubations, as we mentioned. As you see, I repeat some of the important issues just to make them imprinted in your brain. I mean this. It is not just to make it boring. Maternal chorioamnionitis, there is a debate, but I believe it's a risk factor. Maternal hypertension disorder, especially eclampsia and preeclampsia. Endomethacin giving to the mother, not to the baby, might lead to IVH, and it's debatable. The mode of delivery, some people think that vaginal delivery is more risk than C-section. I don't know if this is correct or not. Cord milking. Delayed cord clamping is appropriate for a preterm baby, but cord milking is not a good idea for preterm babies between 23 and 27 weeks, and this could be a risk factor for GM-IVH. Neonatal transport, if you have a baby coming from Kafr Dawar, the guys who are doing the transport should do it in a very gentle way. You are transporting a very vulnerable, fragile, immature baby with high risk of GM-IVH. You are not just bringing somebody. I know how the people might think about transport. Hypotension, rapid increase in blood pressure, enduring cardio is very careful because you could cause with your aggressive intervention severe IVH. As we talked about pneumothorax, respiratory distress, intubation, multiple intubation attempts, bicarbonate therapy, coagulopathy, hypothermia. This is one of the items that we don't take care of, especially when we are resuscitating a very sick preterm baby and we don't care about the temperature, which is hypothermia is killing. It can kill the baby, can interfere with the metabolism. It can make the baby more vulnerable to all problems, including GM-IVH. What is the ideal temperature of the baby and what is the ideal temperature of the delivery room? The ideal temperature of the baby should be between 36.5, 37.5. Okay? And hypothermia is mild, moderate, or severe, depending on how low is the temperature. And the delivery room temperature should be between 23 and 25. And I noticed that, especially in C-sections, because the obstetricians are surgeons, and you know how surgeons behave. Usually they like to have the air condition working and they don't pay attention to the baby, especially if the baby is preterm. And we talked about anemia. If the baby has initial low hematocrit, this is a very high risk. And also some people think there is genetic factors, and these are the genes and how they are and their alleles and what is the effect on GM-IVH. There is another important factor which I will mention later because it is in the prevention, which is if you don't give the mother steroids in the proper way, betamethasone or dexamethasone, at least within 7 days, complete course, either 4 doses or 2 doses, depending on what you are giving, this is a high risk factor for GM-IVH. Some people think that the time of delivery, if the baby is delivered after midnight, because there will not be good enough experienced providers. I don't know about that. You can divide the risk factor. Yes.
دكتور إيهاب معلش هو حضرتك قلت البيتا ميثازون والدكسا ميثازون are great risk factor for IVH
if you don't give them.
If you don't give تمام شكرا
yes, if you don't give them. You can divide the risk factors into prenatal, perinatal, postnatal, maternal, fetal. It's up to you. And one of the important risk factors postnatal is the patent ductus. Because there is a steal phenomenon. The ductus, if there is left to right shunt, it's a steal phenomenon where the ductus steals blood from important organs, including the brain, including the gut, making the baby at high risk for neck or for GM-IVH. Okay, so in vitro fertilization, if there is no antenatal care, if there is no corticosteroids administered, chorioamnionitis, multiple gestation, of course, prematurity, maternal HIV, fetal distress, vaginal delivery, extreme prematurity, very low birth weight, low Apgars. Yes, low Apgars might be predictive of GM-IVH. If the Apgars are very low, especially at 5 minutes, this baby is at high risk to develop GM-IVH. Neonatal transfer, as we mentioned, medications like inotropes, hydrocortisone given to the baby. This is perinatal. Sodium bicarb, acidosis, opioids, anemia, blood transfusion, neonatal sepsis. This is everything that we have in the NICU. That's why the prevention is not an easy task. It's a very challenging issue. Okay, patent ductus, respiratory distress syndrome, hypocarbia, hypoxemia, high pneumothorax. Okay, you can divide them into prenatal, perinatal, postnatal. Why this is important? Because when you do prevention, you think, what are the risk factors? How can we prevent it? By preventing the risk factor, or by early detection of risk factors, or by early management of risk factors. Okay, so the prevention can work. At least you can try to prevent, if not make the GM-IVH less severe, at least make no complications allowed to happen. And then another classification for the risk factors. Delivery room is extremely important. What are the factors in the delivery room that increase the risk factor for GM-IVH? Because as we are going to see in the prevention, there is what they call the care bundle, which focuses on the delivery room and on the what they call the golden hour and the first 24 hours in the prevention. Okay, and in the delivery room, as we said, hypothermia, hypoxia, hypotension, hypercapnia. Okay, so antenatal steroids, as we said, it's extremely important. Maternal choreo, we talked about that. Hypertension, medication, especially indomethacin. Be careful, indomethacin during delivery to the mother is different from indomethacin giving to the baby. Be careful about that. Okay, epidemiology. The risk, the incidence of GM-IVH is high, although there is a lot of advances in the NICU management, but because there is a lot of delivery of preterm babies now, as low as 22 weekers can be delivered and resuscitated, and they can live. So the incidence is still high. Okay, so if some people say it's the average for babies less than 1,500 grams is 25%. But if you go to babies less than 500 grams, it might be as high as 50%. And this is going to be reflected on the morbidity and mortality, as we are going to see later. The lower the gestational age, the higher chance of having GM-IVH. And the different studies were done depending on what preterm babies that the study was conducted on them. The incidence will vary. Okay, and the GM-IVH is inversely proportional to the gestational age. And this is the severity of the GM-IVH severity. not the whole GM-IVH, only the severe ones based on gestational age. And as you see, 22 to 23 weekers, up to 45% have severe, where in 30 to 32, only 2% might have severe. Some people think the sex might play a role. Some people say females are more liable to GM-IVH. I don't believe that. Most IVHs occur when the neonate is younger than 72 hours. More than 90% of GM-IVH occurs in the first 72 hours, and more than 50% in the first day. But if there is GM-IVH, and even if it progresses, we don't see it after 7 days de novo. It is very, very unusual to have a preterm baby who is more than 7 days old and did not have GM-IVH before, to have it after 7 days. This is extremely important in your differential diagnosis and management, and how you see GM-IVH. If you're seeing a baby who is 10 days or 1 month old, preterm, no GM-IVH before, don't think of GM-IVH now. Okay? Term babies, they could have intraventricular hemorrhage, but it is totally different from that in the preterm babies. Usually it's secondary to trauma or asphyxia. It comes from the choroid plexus, not from the germinal matrix. So it is a totally different disease. And then the mortality could be up to 50%, from 27 to 50%, based on how severe is the GM-IVH. Clinical presentation, of course, in any condition, we have to take history, we do physical exam, and then we do labs, imaging, differential diagnosis. So GM-IVH presentation could vary dramatically. Many of the babies are silent. They are asymptomatic. And that's why we should screen those preterm babies, because the baby could be having no symptoms, but have IVH. And you should look for that by doing the screening. And in your unit, you should have a screening schedule, guidelines based on the gestational age, on how frequent you do the monitoring, how frequent you should monitor or screen your preterm babies for GM-IVH. History, either maternal, antenatal, perinatal, postnatal, and to make a long story short, if you find any of the risk factors in the history or any of the events postnatally in a preterm baby, you suspect GM-IVH. Okay? Physical exam depends on how bad is the presentation. The presentation could be asymptomatic with negative physical exam, or there could be dramatic deterioration in the condition of your baby, and you might code the baby because the baby all of a sudden became shocky with severe pallor. As we saw, the ventricular system can accommodate a huge amount of blood. So the baby could have become anemic and shocky because of hypovolemia. And there is in between, okay? So there is a wide variation in the presentation. Some of the presentation that you should take care of, if you have sudden unexplained drop in the hematocrit, if your baby becomes pale with poor perfusion or is in hemorrhagic shock, Okay, significant clinical deterioration associated with anemia, metabolic acidosis, glucose instability, respiratory acidosis, apnea, hypotonia, and so. And we see this presentation in very severe cases. Okay, so timing, as we said, most of the cases in the like 50% in the first day, maybe in the first 6 hours. It is not unusual to diagnose it at birth, even 17%, and then the risk in, decreases by days. After 7 days, no GM-IVH de novo, and then in the first 3 days of life, most of the cases, like 90%. Okay. So this is the timing, which is extremely important. That's why screening for the GM-IVH should start in the first day. Okay. So 3 distinct presentations, if you need to classify: silent, saltatory, or stuttering, which give you, which is the most common presentation. It takes hours for the baby over, or even several days, to deteriorate, giving you non-specific findings, as we mentioned before: altered level of consciousness, hypotonia, decreased spontaneous and elicited movements, subtle changes in eye position and movement, alteration in the respiratory pattern, and then the catastrophic deterioration, which is the least common but is the most serious, and the baby will deteriorate immediately. You have to code this baby. Baby will go into, in seconds or minutes, into coma, irregular breathing, hypoventilation, apnea, decerebrate posturing, seizures, flaccid weakness, cranial nerve abnormalities, bulging anterior fontanelle, and other findings: hypotension, bradycardia, etc. And of course, anemia. Screening, this is extremely important. You have to screen for GM-IVH because in many babies, the presentation could be silent in up to 50%, 25 to 50%. So if you don't screen, you will miss it. And if you miss it, it's not a good idea. Okay? Any baby who is less than 32 weeks should be screened for GM-IVH by serial ultrasound monitoring, period. Okay? And this is some guidelines carried out in some other NICUs. You may or may not take it, or you might have your own. But I will give you an idea about how they do it in some NICUs. If the baby is less than 28 weeks, they do once on admission and then 2 to 3 times during the first week. And usually, if it doesn't happen in the first 7 days, I don't think you need to do any follow-up. But they keep going till the baby, they do it weekly till the baby is 34 weeks. I don't know why. And then every 2 weeks, maybe if there is hemorrhage. If there is hemorrhage, and if they find hemorrhage, they do it weekly until 34 weeks corrected age, and then every 2 weeks. And then at the time of discharge, or when the baby is corrected term. And then if between 28 and 32, they have a different schedule. Above 32 weeks, you don't need to do it unless there is something very suspicious. Sometimes you need to do more frequent surveillance if the baby having severe IVH. If the baby is very sick, you might do it earlier or more frequent. Okay, or if there is post-hemorrhagic ventricular dilatation or hydrocephalus. So the diagnosis of GM-IVH, the gold standard is cranial ultrasound, period. And I am not going to talk much about it because they are more experienced than myself in doing cranial ultrasound. And you, of course, you have to do other labs like CBC and DEF to see if there is platelet, low platelets, blood gases, because it will affect the occurrence and prognosis of and severity of GM-IVH. You have to rule out sepsis, check electrolytes, blood sugar. You might need to do EEG, especially if the baby is having seizure, and coagulopathy if to rule out coagulation disorders. So cranial ultrasound is the gold standard. And this is the normal ultrasound, and it shows you in a coronal section what are the structures, like the lateral ventricle, the corpus callosum, whatever. You are more familiar with that than myself. And this is the parasagittal. It shows you the important structures we talked about before surrounding the ventricles. Also, this is known. Okay, CT does not have a role in the GM-IVH. MRI, yes, it has a role, but not as early as the ultrasound. It's usually if you suspect severe or GM-IVH or complications, and you cannot do it unless the baby is stable. So usually it is done late to rule out associated white matter injury, post-hemorrhagic ventricular infarction, dilation, hydrocephalus, cysts. It is more sensitive than ultrasound in these areas, in these problems. And these are examples of the MRI, which shows you the post-hemorrhagic ventricular dilation. And this is grade 3. Also, this is grade 3, but there is hydrocephalus now. And this is, yes, another dilatation and ultrasound, MRI showing dilatation. This is post-hemorrhagic ventricular infarct in the MRI. Differential diagnosis, it's differential diagnosis is very wide, including other causes of intracranial hemorrhage, sepsis, apnea, cardiac problems, respiratory problems, it's a very, very long list. Morbidity and mortality, we talked about that. Complications. The complications is either post-hemorrhagic ventricular dilatation or hydrocephalus, which might be obstructive by a blood clot in the aqueduct of Sylvius, or non-obstructive, interfering, causing inflammation of the arachnoid villi, making the absorption of CSF less. So it's non-obstructive. And post-hemorrhagic hydrocephalus because of the massive amount of blood in the ventricle. So hydrocephalus is a complication, post-hemorrhagic ventricular dilatation is a complication. And then this, we can divide them into acute and chronic complications or sequelae. The long-term, because of white matter injury, parenchymal injury, and it is developmental impairment, cerebral palsy, seizures. These are important, very, very important long-term sequelae. So if you, yes, short-term, like expansion of hemorrhage, transient ventricular expansion, or long-term, including post-hemorrhagic hydrocephalus, or the neurodevelopmental sequelae, motor and cognitive developmental delay, seizures, as we mentioned. The incidence of significant neurodevelopmental sequelae increases, of course, with the grade. It usually occurs with the severe one, which is grade 4, grade 3, grade 4. Neurodevelopmental sequelae are likely due to the destruction of the periventricular long motor tracts, loss of glial precursors, as we mentioned before, and the periventricular germinal matrix, complications of ventriculoperitoneal shunt if there is a shunt. Okay? So how they develop, what is the pathogenesis of these sequelae? Destruction of the cerebral parenchyma, white matter, or post-hemorrhagic hydrocephalus, or complications of the shunt, as we mentioned, parenchymal hemorrhage, necrotic areas that form cyst or porencephalic cyst, and interfere with the intellectual disabilities and seizures. Okay? And what kind of neurodevelopmental delay we expect? It depends on the anatomic structures of the periventricular region. The cortical spinal motor tracts run in this region. Okay, so there is initially the lower extremities, and then the trunk and the arm. That's why usually the lower limbs are more affected. Okay, and then you can have the spastic diplegia, or if the injury is massive, you will have hemiplegia, spastic hemiplegia. If it's bilateral, it's quadriparesis or quadriplegia, which is very, very bad. And then destruction of the germinal matrix, as we said before. Okay. How does the post-ventricular hemorrhagic dilatation or hydrocephalus occurs? Decreased absorption of cerebral spinal fluid, as we mentioned, which cause communicating hydrocephalus because of the obstruction of the arachnoid villi by blood and debris. Obliterative arachnoiditis, this will cause, as we said, communicating hydrocephalus. Obstruction of CSF, this will cause obstructive hydrocephalus. And we have to differentiate, because I know that you do serial LP for the management of the post-hemorrhagic ventricular dilatation and to prevent hydrocephalus. I know that you do that, but you have to do ultrasound, and you have to be sure what are you dealing with. Is it obstructive or communicating? And many, as we are going to see, many people deny the benefit of serial LPs. Okay. Alteration in cerebral blood flow also will lead to global hypoxic ischemic injury to the whole brain. So the same pathology that initiated GM-IVH will also affect the rest of the brain. And that's why you might find PVL. PVL is a totally different pathology and different entity, but it could be associated with the GM-IVH, but it is not a complication of GM-IVH. So PVL, post-hemorrhagic periventricular leukomalacia, could happen. It's a very serious problem. It affects the white matter in the brain, and the etiology is non-hemorrhagic ischemic necrosis. Non-hemorrhagic ischemic necrosis, and it is very serious, and it can lead also to CP, and it's a serious problem. Okay. So what are the risk factors for the post-hemorrhagic ventricular dilatation? It is severe GM-IVH. This is the most, it's grade 3 or grade 4, or what we call post-hemorrhagic ventricular hemorrhagic ventricular infarct. Okay, and depending on the severity, these are the percentage of the complications. Like if you have grade 1, you have only 1%, compared to grade 4, you have 28%. So it's the severity. And this diagram shows the different multifactorial issues that lead to complications. And as we said, it's a combination of inflammation, hemolysis of red cells, immunological response, hypoxia, ischemia, decreased cerebral blood flow, and the end result will be post-hemorrhagic ventricular dilatation or associated PVL, which is not a complication of GM-IVH. Even cerebellar damage could happen. Now, some people use biomarkers for the diagnosis of GM-IVH. It is still under investigation. It's not a current practice. And sometimes they do it in the cord blood, and usually they do it after delivery. And the most important one of them is the neuron-specific enolase, which is a useful biomarker for the identification of preterm neonates at high risk for developing a grade 2 and grade 4. I don't know what is NBI. I don't know. Neuronal, I don't know. Brain injury, yes. Neuronal brain injury. So neuron-specific enolase. So how does the post-hemorrhagic ventricular dilatation present? Usually, it starts to show up within 3 weeks. And the most important screening and monitoring that you should do in addition to the cranial ultrasound is serial measurement of the head circumference, which is very sensitive and it helps a lot. So increased head circumference in signs of increased intracranial pressure in severe cases after several weeks. So it could be either, what is the prognosis? What happens to the post-hemorrhagic ventricular dilatation? 40% will have spontaneous arrest. That's why some people might say, oh, why we are doing serial LPs? Let us wait and see, is it going to regress or not? Because it can regress in yes, in 40%. Or it could progress rapidly in only 10%, and it could have persistent slow progression in 50%. Dr. Hamdul is calling me now. I'm sorry, I will not be able, I'm not able to take his call. I'm sorry, dear friend. Okay, this is what happens. What happens for PHVD. However, small subset of PHVD initially appears to have arrested spontaneously or in response to treatment, and then will progress lately to ventricular dilatation. So you have to be careful. Even if the baby regresses, you have to keep following up this baby with serial ultrasound and maybe with MRI. Okay? This happens usually during the neonatal period, but rarely can occur. But there is a very, very minute chance it might occur in the first year of life. The rest of mortality and impaired neurodevelopmental outcome are great in preterm infants who develop PHVD. And we know why. So serial monitoring is extremely important. And some people recommend to do it twice weekly, up to 4 weeks. till we are sure we don't have PHVD, or we have. Now, there is, I believe you should know that, because I think you know it better than me. What are the indices we check? So I will just mention it. And Dr. Marwa, do you do this indices or not?
Yes, doctor, we do different measurement of the ventricle, including ventricular index.
Okay, so no, you have, yes, we have ventricular index here. You do this, okay? You do ventricular
Yes,
index, okay, which is
we
defined,
do measure the
it is the distance between the falx and the lateral wall of the anterior horn based on imaging through the coronal plane at the level of the foramen of Monroe. This is what you do?
Yes. أيوة يا
Okay,
دكتور، ده واحد من الميجرز اللي بنستخدمه.
great. We have also the thalamo-occipital distance. Do you do that?
Yes.
Okay, which is distance between the outermost point of the thalamus as it at its junction with the choroid plexus and the outermost part of the occipital horn in the parasagittal plane. And there is numbers for these indices, and when usually if the number is more than the 97th percentile, you consider it abnormal. And there is also frontotemporal horn ratio and frontal occipital horn ratio. Do you do that?
No. No.
Okay, it's measuring the widest distance of the frontal and occipital horns, respectively, and temporal horns, and dividing the average of these measurements by twice the largest biparietal distance. It's a lot of math. If you need to do it, it's up to you, but this is, they have three indices: ventricular index, thalamo-occipital distance, frontal temporal horn ratio, and frontal occipital horn ratio. And these are the guidelines you depend on to decide what you are going to do with PVHD. So, and these are the interpretations, and it depends on the depending on the interpretation, either there is no PHVD and there is no signs of dilatation on serial ultrasonography, or you have moderate if it is less than the ventricular index, less than 97th percentile, and there is some other measurements, and less than 4 millimeter above the 7th, yes, either less than 97th percentile or less than 4 millimeter above the 97th percentile. You consider it moderate. Severe if the ventricular index is more than 4 millimeters above the 97th percentile. Okay, and AHW more than 10 millimeters. What is the AHW? I don't
Anterior
know.
horn width. Anterior horn width.
So you use this?
Yes,
Do you
it's
use these
easy.
parameters?
Yes, it's anterior
Okay,
horn width.
great. Okay. So you divide it into mild, moderate, severe, and then based on that, you decide what to do. And there is a good point here. You have to differentiate PHVD from progressive or, non-progressive or stable ventriculomegaly. You might see a baby preterm with GM-IVH who has ventricular dilatation, but it is stable and non-progressive. And you have to differentiate it from PHVD because it is self-limited and it will resolve. You don't need to interfere with that, okay? Okay. And then there is the white matter injury. It's another complication, serious one. And it is detected by ultrasound, but more and better with the MRI. And this is the cause of the neurodevelopmental delay. Also, there is cystic PVL, periventricular leukomalacia, which is not part of GM-IVH. And these are the indices. Okay? You know it better than me. Okay, management of the GM-IVH and the complications. There is general supportive measures, cardiovascular, hemodynamic stability, maintaining blood pressure, dealing with the underlying problems, hypotension or respiratory distress, correction of anemia, correction of acidosis, hypotension. These are serial supportive care, and you have to take care of blood pressure management. Important issue is fluid and nutritional support, respiratory support, and we talked about asynchrony between the baby spontaneous breaths and ventilation breaths. Correction of any coagulopathy. Okay. Some people give, yes, I believe you do that practice, but I don't know, some people don't like that. Giving fresh frozen plasma. It should be given if there is a coagulopathy, but if there is no coagulopathy, it doesn't have any value. I don't know why you do that. It's your own practice. Limited data are available on the use of, oh yes. Another factor is recombinant factor 7. Same story. It has little or no value unless there is evidence of coagulopathy. Also, you have to manage seizure, and we are not going to talk about that. We discuss seizure in another presentation. Pharmacologic interventions, still controversial. And I'm going to give you some of these examples. Monitoring, yes, we should, he said, monitor the baby clinically, checking head circumference, looking at the clinical presentation, symptoms and signs, and also by the serial ultrasound. Extremely important, clinical and ultrasonographic monitoring, because many people could be asymptomatic. So you have to do, Dr. Amara, do you have like a schedule for monitoring babies with cranial ultrasound?
دكتور هو احنا ماشيين يعني day 1 day 3 day 7 كل النواب عارفين كده. بعد كده بقى يعني ممكن نعمل عند اليوم ال 14 وعند اليوم ال 28
If there was initial hemorrhage, correct? If there was
yeah.
hemorrhage.
Yes, if
But
there is
if there
hemorrhage.
was no hemorrhage, I believe you stop after day 7.
Yes, yes.
Okay, good. And then some investigational interventions, like, yeah, I believe we might need integrated EEG if the baby is having seizure. The near infrared spectroscopy, the diffuse correlation spectroscopy, these are investigational procedures, looking for biomarkers, as I said before. And then consultation, you should consult the neurosurgeon and the neurology. And then developmental intervention to see the baby after discharge. Management of post-hemorrhagic ventricular dilatation. And we said it could be mild, moderate, or severe. Mild, no intervention. Moderate, there is an algorithm for that. High risk, we said who are the high risk people. You need to do, if it was mild, there will be resolution. If it's persistent, moderate, or severe, we have to interfere. Usually it shows up after 1 to 2 weeks. What we do is persistent ventricular dilatation. We do drainage at 4 to 6 weeks. What we do the serial LP, the device, ventricular device to aspirate CSF, direct ventricular drainage. We have the subgaleal shunt, and lastly we have the peritoneal or arterial shunt. And there we have criteria for that. I don't know if you do it, but usually it is determined and dictated by the neurosurgeon, who like to see a baby who is more than 2 kilograms. Some use 2.5 or higher. CSF proteins less than 1.5. Some people say less than 2, and CSF red cells less than 100. These are the criteria for the ventriculoperitoneal shunt. So if the babies are symptomatic, as I said, with increase in head circumference more than 2 centimeters every week, this is extremely important. And using the indices we talked about, we might do serial lumbar punctures. Some people do it, others do not like it. Some people think it's useless. Others like to stay and wait and see, because 40% might resolve. So a more recent systemic analysis showed no evidence that repeated CSF removal via lumbar puncture, ventricular puncture, or even from ventricular reservoir has any benefit over any conservative management in infants at risk for developing post-hemorrhagic hydrocephalus with regard to reducing disability, mortality, or requirement for permanent shunt placement. This is one of the schools that denies and just keep the baby, and if the baby needs shunt, well and good. If not, just wait and see. And this is, yes, go ahead.
دكتور إيهاب كنت
نعم.
بسأل حضرتك إيه أقل وزن بيتعمل فيه شنط عند حضرتك يعني أو كان بيتعمل
I just said it. You didn't hear me. I just said it. 2 kilograms, and some people use 2.5. Do you see this slide?
Yes.
Yes, 2 kilograms or higher. Some people use 2.5, and CSF proteins 1.5, less than 1.5 or less than 2, cells less than 100. So serial LP, and we talked about the indication and how we do it, and we do the tap 1 or even twice per day. And here's the criteria again for the shunt. Of note, in neonates with findings that are concerning for elevated intracranial pressure, like asymmetric pupils, bulging anterior fontanelle, markedly decreased mental status, cranial ultrasonography should generally be obtained before doing LP. Because this, I believe I told you this not before, when I knew that you do serial LP. Why? In some cases, there may be finding on ultrasound that would make it useful to perform unsafe to perform LP. Example, significant ventricular dilatation with a large third ventricle and a small fourth ventricle, meaning the aqueduct is stenosed. And if you do LP, either if the stenosis is massive and there is non-communicating hydrocephalus, it will not be of any help, or it could be unsafe if there will be a rush of the CSF from these dilated areas through the stenotic aqueduct, and this is not safe. Okay, so if you insist to do serial LP, do ultrasound before each and every time. And then acetazolamide, it's useless, limited value. Ventriculostomy, if there is significant hydrocephalus. Ventriculoperitoneal and ventriculosubgaleal shunts remain the definitive treatment for post-hemorrhagic hydrocephalus requiring surgical intervention. And actually, the subgaleal is also transient. The permanent is the peritoneal or arterial. There is also the use of ventricular access device, VAD, which is, I don't know. It is a temporizing measure. It is reasonable to measure to gain time and decisions about insertion of permanent VPS. You can do it, but it is also transient. So these are the surgical support maneuvers. And some people do what they call drift. Drift is direct insertion of right frontal and left occipital catheters with intraventricular injection of tissue plasminogen activator, and that is sufficient to produce a systemic effect. Do the neurosurgeons in Alexandria do this practice, Dr. Marwa?
لا يا دكتور، واحنا
Correction.
كنا اقترحنا على رئيس القسم بتاعهم، يعني ان احنا كان عندنا حالات complicated وعندها adhesions intraventricular، وهو قال لنا ان احنا عادي ممكن نعملها ونعملها trial وكده، بس احنا لما دورنا ما لقيناش غير يعني very very few and old study عن الموضوع ده، يعني فمش عارفة برضو هل حضراتكم بتستخدموه كتير؟
أنا ما أعرف. I'm not familiar with that. This is pure neurosurgery. To be honest with you, I don't know. But it is one of the parameters that you can use. Here comes
وكنا عايزين through the external drain.
through what?
The ventricular external drain, VED.
Yes, the device.
Yes.
The device. Yes. Oh, yes. Ventricular reservoir, VAD. It's also known as ventricular access device, VAD. We have the Omiya reservoir and Macomb reservoir. It's a temporizing also, temporary. It is not a permanent treatment for PHH in preterm infants that may even eliminate the need for permanent shunt in some cases. So you have to try it, and if it's working, it might help to resolve the problem, and you don't need permanent shunt. This is what they say. Do you have these devices?
دكتور يعني احنا شفناها يعني مكتوبة كتير ودورنا عليها بس مش موجودة، ولا بتوع
It's not
نيورو سيرجري.
available.
عشان كده هو غصب عننا بنعمل LB repeated LB لحد ما البيبي يوصل الوزن بتاع البيبي شنط.
Yeah. But anyhow, it is also temporary procedure, but sometimes it can save you the peritoneal shunt, which is a good news. I don't know what is the percentage they didn't mention, but it is one of the parameters or procedures.
وده اللي بيحصل معانا في اللمبر بانكتشر برضو يا دكتور. في أطفال كتير بيبقى الفنتريكولار ميجرز بتاعتهم كبيرة وبتزيد بسرعة وبتثبت لما بنعمل لمبر بانكتشر فترة طويلة لمدة شهرين، بعد
But,
كده
but
بتفضل
they
ثابتة.
could be one of the 40% that have spontaneous resolution. So if you want to see how effective is the LP and what are the indications, you have to do a research. You have to do a controlled trial, a clinical control trial. You compare babies with LP with babies with no LP, and then you see what is the difference, and they should be matching it to each other. you can do it with research. It's a very good point of research. So this is the VAD, which unfortunately you don't have. Yes, this is the ventriculostomy. Ventricular reservoir. This is the VAD. This is the VAD. Okay. And then the shunts, ventriculo-subgaleal, which also temporary, and the terminal is the ventriculo-peritoneal or ventriculo-arterial. And this is an algorithmic approach which summarizes what we said, so I will not deal with it again. We said this already. Some new and investigational studies did try to use some other issues that will help repairing the damage that happened to the brain and to the ventricles. They use recombinant erythropoietin, they use melatonin, stem cell, they use I cannot see well. Let me use my reading glasses. They use hyaluronidase, but all these still experimental, and they are not standard of care. Also, yes, this is an abbreviation of these interventions. Mesenchymal stem cell therapy. It's a promising, but it is still as a research. When you transfer mesenchymal stem cells that you get from the cord blood and you use it. Just give me 1 second. I will be back to you. 1 second. I'm sorry. Hello? You hear me?
Yes.
I'm back. Sorry for the interruption. So mesenchymal stem cell therapy is a very promising point of research, but it's still phase 1, or maybe, still under phase 1, which is animal experiment. But it could be of good treatment, and the aim is to regenerate the damaged neuronal cells and white matter cells. This is the idea now. One of the important medications that could be of great value is caffeine. Caffeine is a magic drug. It's like penicillin in the era of antibiotics for treatment of infection. Caffeine restores neuronal damage and inflammatory response in a model of IVH in preterm newborn animals. They used it in animals. Caffeine treatment restores cognitive deficits in mice with GM-IVH. Brain atrophy is reduced in GM-IVH animals after treatment with caffeine. Caffeine treatment restores neuronal density and curvature. Caffeine treatment limits cortical hyperphosphorylation. Neurogenesis impairment is improved by caffeine treatment. It's like a magic. Bleeding is reduced. So my suggestion is that, Dr. Amaru, for any preterm baby, you have to start caffeine from the get-go, from day 1. And it's a very safe drug. And it stays in the systems for hours, days. So start caffeine for any preterm baby less than 32 weeks. And you can also conduct a very good research study, which is very easy. 2 groups, group 1 with caffeine, group 2 no caffeine, and see if it can prevent bleeding. And if bleeding occurs, how can it help treat brain atrophy and cognitive deficits, which will show up later. You can do it in combination with the pediatric neurology. And Dr. Amar, what do you think about this idea?
دكتور احنا بنبدأ لحالاتنا كلهم كافيين. لو الأطفال أقل من أو يساوي 32 أسبوع بنبدأ لهم كلهم كافيين.
When do you start?
From the start.
From day one.
Day one.
Great.
هي السؤال بس اللي كنت بسأل حضرتك بقى، يعني ايه الماكسيمال دوز اوف كافيين اللي حضراتكم
بتستخدموا؟ is a very safe drug. بس انت هتسأليني في ارقام بقى دكتورة مروة. صعب علي ان انا my brain can tolerate numbers، لكن مش فاكر. I think 20 the number 20 ملغرام per kg
وده فعلا اللي احنا بنستخدمه، بس في few studies مستخدمة ارقام اكبر من كده، فانا بقول يعني
you can go up and you can keep an eye on the baby. What if the side effects or toxicity, it will show up in the form of tachycardia, irritability, excitability, hyperreflexia, okay, which and if this happens, you go down. And do you have the privilege of doing caffeine level in the blood?
No. لكن احنا الحاجات السايد افكتس بتاعت التاكيكارديا او كارديوتوكسيستي سهلة الديتكشن، لكن المشكلة ان هو في كلام عليه دلوقتي ان هو بيعمل فيدنج انتوليرنس في البري تيرم، فدي يمكن اكتر حاجة بتخلينا
it can aggravate the reflux, yes, but you can weigh the benefits and disadvantages, and you have to make your decisions based on that. but it's a magic drug. I don't mind using it. You can go as high as 20 per kg, and you have to use it from the get-go, from day one. And monitor your babies. And if you have the luxury of doing caffeine level, which is something very easy, the lab can do it. I don't know why not. It will be very helpful. Okay?
تمام
Okay.
شكرا.
So prevention, this is the core concept of our talk today. Prevention. Because I believe this is the point you are interested in. So, prevention starts before delivery. Number one, try to prevent prematurity, which is not in our hands. It is in the hands of our colleagues in the labor and delivery guys and in the fetal-maternal medicine, which I don't know if you still have communication with them or not. I'm not going to ask. I don't like to hear bad news. So prevention of the prematurity, okay? How you prevent prematurity? They can use tocolytic agents. They can use sometimes beta blockers, endomethacin, magnesium. They have many interventions that can prevent immaturity. Number two is the antenatal steroids. It's extremely important. Also, it is not in our hands, unfortunately. But if you have good communication and connections and chatting with our fetal-maternal guys, antenatal steroids is extremely important. It prevents GM-IVH, prevents neck.
هما بيستخدموها كتير جدا يا دكتور، يعني نادرا لما بنلاقي حالة مش واخداها يعني.
Okay, great. And then how they work, how the mechanism of action, they can cross the placenta and they can go to the baby and they stabilize the fetal neurovasculature in the germinal matrix. So antenatal steroids. Then comes next is avoidance of conditions that led to the GM-IVH, which if we go back to the risk factors and etiology, and then you do the opposite, try to diagnose as early as possible, try to treat as early as possible, try to make the hemorrhage not to happen, and if it happens, less severe. Okay? And the good monitoring and cranial ultrasound is extremely important. Okay? Factors interfering with the autoregulation, hypocarbia, hypercarbia, hypoxia, acidosis, we mentioned that before. Blood pressure problems, blood volume replacement and fluids resuscitation, extremely important. And then one of the very good items also is that magnesium sulfate, and I shared in this study before because it was 2004, I shared in this study, which is the antenatal or prenatal, the use of magnesium sulfate, giving it to the mother. It has significant neuroprotection and it helps to prevent moderate to severe CP. Also, it is not in our hands. Do our fellows in fetal-maternal medicine give magnesium sulfate to the mom with anticipated preterm delivery?
if time allows، يعني إذا الست ما كانتش جاية بقى في severe hemorrhage أو emergency، لا حقيقي هما بيدوا magnesium sulfate.
Yes. The World Health Organization, American College of Obstetricians and Gynecologists, and the Society of Maternal Fetal Medicine currently recommend the use of magnesium sulfate for women at risk for imminent preterm birth before 32 weeks of gestation for prevention of cerebral palsy during infancy and childhood. It's a very good neuroprotective. And it has many mechanisms for neuroprotection. We don't need to go into that. And okay, one of the parameters that could be used in prevention is NSAIDs. NSAIDs like endomethacin or ibuprofen. And many NICUs use endomethacin for prophylaxis. And it does not only helps to prevent IVH or severe IVH, but also it helps to close the ductus. Dr. Marwa, are you in the practice of using endomethacin prophylaxis?
هو لما بيبقى متوفر بنستخدمه خصوصا للأطفال yes extremely low gestational age.
Why it's not available? It is not it's a cheap medicine.
Yes, but it's not available. يعني مثلا في ال 12 شهر بتوع السنة يعني الطبيعي ان هو بيختفي 4-5 شهور كده، واحنا مثلا بقالنا دلوقتي بعد بقى الحروب اللي بدأت وكده بقالنا حوالي مثلا حوالي سنة مش موجود في السوق خالص في أي حتة.
Okay, never mind. Okay. Head positioning, extremely important. We talked about that. It should be in the midline, not to one or the other side, and head should be of the incubator elevated. And this is postnatal prevention strategies, stabilize blood pressure, free radical production, prevent asynchrony in breathing. We talked about that. Prompt platelet adhesion, increase capillary. Yes, keep an eye on the platelets. Free radical protection. I don't know. Oh, vitamin E. Sorry. They give phenobarbital. They give paviolone. I don't know what is paviolone. Ethamsilate, vitamin E, endomethacin, ibuprofen, factor 7. And unfortunately, maybe the only one that may be used is or proved efficiency is the endomethacin. Yes, there is something called care bundle. This was induced by some groups of neonatologists, and they use it, and they use it in what they call the golden hour, and they use it in the first 72 hours, and it has some parameters. It has 4 steps, and you may use it if you need. So a care bundle is structural, organized attempt to develop protocols. You can have your own protocols to prevent or alleviate possible major risk factors for a disorder like GM-IVH. So GM-IVH is a complex multifactorial disorder, and they did this care bundle to take care of the baby in the first 72 hours to improve neonatal outcome. So they have 4 points. Appropriate neonatal resuscitation, and so there is delivery room precautions, and if possible, delayed cord clamping. Delayed cord clamping helps prevent anemia and GM-IVH. Golden hour care of an infant. The first hour of life is called golden hour, and they do some precautions in this first hour to protect the baby from GM-IVH. Gentle care of outborn infants transport, including safe transport, avoiding hemodynamic instability. The guys who do the transport should be, might be physicians, might be neonatologists, physician assistant, but whoever is doing the transport should be aware of these precautions. And management of perinatal thrombocytopenia and coagulopathy. This is for any baby. And these are photos that shows you what they do antenatally, what they do in the NICU, starting from the delivery room. And and transport and perinatal care. These are the 4 points they stressed on. They call it care bundle. And then comes the golden hour. I'm sorry for the small, I couldn't make it bigger. So antenatal counseling team, delayed cord clamping, prevention of hypothermia, timely and appropriate respiratory support, cardiovascular system support, nutritional support, infection control, laboratory investigations, monitoring and record keeping, family counseling. This is what they call the golden hour, which is the first hour of life. And this is the QI project improvement, and this is the fishbone project, and these are the risk factors and how they can prevent it and how they can improve it. Okay. And these are also strategies to improve standardization of GM-IVH care bundle, starting from the antenatal care, perinatal, patient positioning, nursing care. Nursing care is extremely important. And we talked about handling of the baby, minimize, and you know what? Also minimizing the noise and taking care of the pain of the baby, because if the baby is straining because of pain, he might have GM-IVH, the preterm baby. If there is a lot of noise, it causes hemodynamic instability and will interfere with blood pressure and with cerebral blood flow. Okay. And care procedures, minimize procedures as much as you can, minimize labs as much as you can, give the baby time to rest, and these are summary of recommendations, and these are important issues. I'm going, if you notice, I'm repeating issues, the important issues just to imprint in your brain: antenatal steroids, magnesium sulfate, delayed cord clamping, the ventilation, head positioning, nursing care, care procedures, hemodynamic management. And there is prenatal, perinatal, postnatal issues to prevent other procedures, pain management. Do you have pain management in your NICU for preterm babies or term babies, Dr. Marwa?
prenatal management يمكن بس كان البعض بيحاول في الهيدروبس فيتاليس ان هو
pain.
يعمل اميو برينيت. نعم.
I'm talking about pain management. Pain
مانجمنت. معلش انا اسفه سمعتها برينيتال مانجمنت. بين مانجمنت جلوكوز 10% و use paracetamol, we use fentanyl.
So you take care of pain, and there is a score that shows you. A skilled nurse can tell you this baby is in pain, and once you do these interventions, it will help. Also, the noise.
We have many studies about pain and relaxing maneuvers of preterm. يعني بصراحة اللي ماسكين الموضوع دوت أكتر كلية التمريض بيجوا عندنا وبيعملوا دراسات وبيبقى فيها relaxing maneuvers للبريترم. بيبقى فيها.
Do you know that we have music therapy for newborn babies?
Yes.
It is not unusual to find a lady or a gentleman who in the NICU who is entering with his guitar or violin, and he will sit up close to the bed and start playing. And there was a study that proved that music therapy helps newborn babies, even the preterm ones. Okay, control the environment, about lighting, the light, the distance between every baby and the other. Staff education and training is extremely important. And we should check their qualifications every now and then. So training in education for every person who deals with these preemie babies, whether a nurse practitioner, a physical therapist, a respiratory therapist, or even someone who is coming to do the regular maintenance of the machines, of whatever. Anybody who enters the NICU should have a good amount of education and training. So, prevention of post-hemorrhagic VD, ventricular dilatation. It's a sequelae of severe GM-IVH. So prevention of severe IVH, management of GM-IVH so it doesn't turn, because GM-IVH could start like grade 1 or grade 2 and it then progresses. So don't be excited if you diagnose grade 1 or grade 2 in the first day of life and say, okay, it's only grade 1. No, sir. You still have 7 days for this GM-IVH to progress. It can turn into grade 3 or grade 4, and then will turn into complications. So you have to do interventions as much as you can to prevent. And one of them is, as you do prophylactic CSF drainage. Some people use fibrinolytic agents, which is of doubted value. However, bad news. These interventions have not shown to be effective in preventing PHVD, and as a result, they are not recommended. Some people say that this is bad news. This is the black side of the story, but you have to do your best. And then, yes, talking about prophylactic CF drainage, fibrinolytic agents, prognosis. Grade 1 and grade 2 usually have a relatively good prognosis, but if you follow them up as infants and children, they might have some handicaps, some neurodevelopmental delay, even mild GM hemorrhage localized to the GM. But prognosis is much better for grade 1 and grade 2. Grade 3 and 4, they are called severe, and they have high mortality, high morbidity, as high as mortality as high as 10% for the grade 3, and it's up to 80% for infants with PVHI2 or PVL to have severe neurologic sequelae. So the severer the dilatation or the GM-IVH, the worse is the morbidity and mortality. But low grade is not 100% benign. Be sure about that, okay? Conclusion. It is extremely important to understand the pathogenesis of GM-IVH, and I hope I did a good job with that, and you understand now the pathogenesis of GM-IVH. If you don't, I don't know, it's okay. Mainly because of the associated outcomes and prognosis. Short-term IVH complications include development of post-hemorrhagic ventricular dilatation. Long-term complications and prognosis are dependent on the infant's degree of prematurity. Of course, the extent of hemorrhage and presence of parenchymal involvement. Preterm infants with mild IVH, when compared with those with without IVH, were associated with high odds of death. Still, the prognosis is not 100% benign, and some degree of neurodevelopmental impairment, okay? But there is no increase in the cognitive delay or cerebral palsy, which is some of the good news. Infants with severe IVH are at even higher odds of developing moderate to severe neurodevelopmental impairment, cerebral palsy, and cognitive delay. The reduction in rate of severe IVH over the last few decades is likely because of advances in perinatal and postnatal medical care and research. As we continue to define GM-IVH risk factors and adapt our practice guidelines, we hope to see an even future reduction in the incidence of grades of IVH, of all grades of IVH, and its associated short-term and long-term complications based on assess the risk factors. Interventions have been tried to decrease poor neurological outcome during the fetal period, starting from the fetal prevention, like treatment of chorioamnionitis and magnesium sulfate and antenatal steroids, and then comes delivery room interventions, and then comes neonatal and postnatal interventions. The homegoing message is understanding the pathophysiology of germinal matrix intraventricular hemorrhage in preterm infants and considering of the future directions for treatment and prevention is the homegoing message. And thank you very much. And I have some MCQs, but we are already now 2.5 hours. So maybe when I send you this presentation, you will look at the MCQs and try to solve them. I hope I did a good job, and I will be happy to have any feedbacks or any comments and any questions, suggestions.
شكرا جدا لحضرتك يا دكتور، حقيقي مجهود كبير، يعني ربنا يدي حضرتك العافية يعني عليه. يعني احنا استفدنا جدا يعني IVH from A to Z يعني. بس انا كنت بسأل حضرتك بقى على حاجة حضرتك قلتها في النص، اللي هي الامبليتيود انتجريتد EEG. كنت بسأل حضرتك
This is for the EEG, because they are very liable to have seizures either early or late, and one of the bedside EEGs that you can use and you don't need to be a neurologist is the integrated whatever EEG.
أنا بسأل حضرتك على الديفايسز اللي حضرتك شفتها، كانت part of the monitor ولا كانت separate devices؟ عشان احنا بنحاول نجيب يعني.
دكتورة مروة حضرتك بتسأليني very technical questions. I don't know the answer. I'm sorry.
طيب هو كان موجود عند حضرتك في الوحدة؟
الحقيقة لا. I started knowing and reading about it when I retired. So I'm sorry, I didn't use it. I'm not expert, but I know that it can help. It's very helpful. You don't need to have a neurologist. You can do it on your own, and you can interpret it on your own. And then if there is something that needs further EEG sophisticated, you can ask the neurologist to come and do it. But I'm sorry, I don't have any experience with this.
أسفة على أسئلتي دايما، بس يعني بنحاول نجيب واحد يعني محتارة بين جهاز عادي يعني وجهاز part of the monitor يعني.
Let me do some research, and then I will come back to you with an answer if possible. Give me some time and I will do research for that.
يا ريت يا دكتور، شكرا لحضرتك.
No problem. Okay, next talk, I'm going to talk also Wednesday. It will be MCQs, index of suspicion, and some visual diagnosis cases. Thank you very much, and appreciate attending this presentation, and I hope it was helpful. Okay?
شكرا.
Thank you very much. See you, inshallah, Wednesday. مع السلامة.
إن شاء الله. مع السلامة.